Okay, let's start with first conventional antipsychotic. Alphabetically, let's start with chlorpromazine, which has the trade name of thorazine, and it is a low potency D2 blocker. Anyways, chlorpromazine has the brand name of thorazine. It has generics, of course. The class neuroscience, let's say that neuroscience-based nomenclature. It is dopamine and serotonin receptor antagonist. It is a conventional antipsychotic. We call it neuroleptic, of course. Phenothiazine, a D2 antagonist, and it can be used as an antiemetic. Commonly prescribed for these bold for FDA approved, of course. We use it for schizophrenia, nausea, vomiting, restless and apprehension before surgery, acute intermittent porphyria, manifestations of manic type of manic depressive illness, tinnitus adjunct, intractable hiccups, competitive or explosive hyperexcitable behavior in children, hyperactive children who show excessive motor activity with accompanying conduct disorders consisting of some or all of the following symptoms like impulsivity, difficulty sustaining attention, aggressivity, mood lability, and poor frustration tolerance. We use it also for psychosis, and off-label we can use it in bipolar disorder. Okay, how the drug works. It blocks dopamine 2 receptors, reducing positive symptoms of psychosis and improving other behaviors. Combination of dopamine D2, H1 histamine H1, and cholinergic M1 blockage in the vomiting center may reduce nausea and vomiting. So, it blocks H1 and also M1. How long until it works? Psychotic symptoms can improve within 1 week, but it may take several weeks for full effect on behavior. Action on nausea and vomiting are immediate, of course. Okay. If it works, what to do? Most often reduces positive symptoms in schizophrenia, but does not eliminate them. Most schizophrenic patients do not have total remission of symptoms, but rather a reduction of symptoms by about a third. Continue treatment in schizophrenia until reaching a plateau of improvement. After reaching a satisfactory plateau, continue treatment for at least a year after first episode of psychosis in schizophrenia. For second and subsequent episodes of psychosis in schizophrenia, treatment may need to be indefinite. Okay, reduces symptoms of acute psychotic mania by not proven, but not proven as a mood stabilizer or as an effective maintenance treatment in bipolar disorder. So, for psychotic, yes, but it's not as mood stabilizer. It's not used as mood stabilizers, at least not proven. After reducing acute psychotic symptoms in mania, switch to a mood stabilizer and or an atypical antipsychotic for mood stabilization and maintenance. Okay, we can repeat a lot of these in other typical antipsychotics. If it does not work, consider trying one of the first-line atypical antipsychotics like risperidone, olanzapine, quetiapine, risperidone, ziprasidone, aripiprazole, paliperidone, amisulpride, acinapine, iloperidol, or lorazepam. So, atypical antipsychotics. And consider trying another trying another conventional antipsychotic. If 2 or more antipsychotics monotherapies do not work, so you consider clozapine, of course, for treatment-resistant schizophrenia and so. Best augmenting combos. Augmentation of conventional antipsychotics has not been systemically studied, so usually in schizophrenia, and so we are talking about using one drug. Okay. Addition of a mood-stabilizing anticonvulsant such as valproate, carbamazepine, or lamotrigine may be useful in both schizophrenia and bipolar mania. Augmentation with lithium in bipolar mania may be useful. Addition of a benzodiazepine, especially short-term, for agitation. Okay, what about tests? Since conventional antipsychotics are frequently associated with weight gain before starting treatment, weight all patients and determine if the patient is already overweight, the body mass index between 25 and 29.9, or obese, more than 30. Okay, you do that. What else? Before giving a drug that can cause weight gain to an overweight or obese patient, consider determining whether the patient already has prediabetes, fasting plasma glucose between 100 and 125 mg per deciliter, or diabetes has fasting plasma glucose more than 126 mg per deciliter, or dyslipidemia, increase in total cholesterol, LDL cholesterol and triglycerides, or decreased in HDL cholesterol, and treat or refer such patients for treatment, including nutrition and weight management, physical activity, counseling, smoking cessation, and medical management. Okay, you monitor weight and body mass index during treatment. Consider monitoring fasting triglycerides monthly for several months in patients at high risk for metabolic complications and when initiating or switching antipsychotics. While giving a drug to a patient who has gained more than 5% of initial weight, consider evaluating for the presence of prediabetes, diabetes, or dyslipidemia, or consider switching to a different antipsychotic. You should check blood pressure in the elderly before starting and for the first few weeks of treatment. Monitoring elevated prolactin levels of dubious clinical benefit. Phenothiazines may cause false positive phenylketonuria results. Okay, and this drug is one of them, okay, phenothiazines. Patients with low white blood count or history of drug-induced leukopenia or neutropenia should have complete blood count monitored frequently during the first few months, and chlorpromazine should be discontinued at the first sign of decline of WBC in the absence of other causative factors. Okay, this is about therapeutics. Let's talk about side effects. How drug causes side effects. First, by blocking dopamine D2 receptors in the striatum, it can cause motor side effects. This is the nigrostriatal pathway. Okay. By blocking dopamine D2 receptors in the pituitary, it can cause elevation in prolactin. This is a tuberoinfundibular pathway of dopamine. Or by blocking dopamine D2 receptor excessively in the mesocortical and mesolimbic dopamine pathways, okay, especially at high doses, so it can cause worsening of negative symptoms. This is for mesocortical pathway, and cognitive symptoms, also mesocortical with some mesolimbic pathway, okay, which we call neuroleptic induced deficit syndrome. Okay, worsening for negative symptoms and cognitive symptoms. Another effects other than dopamine things, anticholinergic actions may cause sedation, blurred vision, constipation, dry mouth, and antihistaminic actions may cause sedation and weight gain. By blocking alpha-1 adrenergic receptors, it can cause dizziness, sedation, and hypotension. Mechanism of weight gain and any possible increase in incidence of diabetes or dyslipidemia with conventional antipsychotics is unknown actually. Okay. We have some notable side effects. As we said before, neuroleptic induced deficit syndrome, akathisia, priapism, extrapyramidal symptoms like Parkinsonism, tardive dyskinesia, okay. Galacturia and amenorrhea, of course, this is because of hyperprolactinemia. These are the prominent side effects. Other side effects, and they are side effects actually, and they are common somehow, but maybe less dangerous. That's why they are here like this. Okay, dizziness, sedation, impaired memory, dry mouth, constipation, urinary retention, blurred vision, decreased sweating, sexual dysfunction, hypotension, tachycardia, syncope, and weight gain. What about life-threatening or dangerous side effects? Okay, rare neuroleptic malignant syndrome, so you should put that in your mind. Rare jaundice or agranulocytosis, rare seizures, increased risk for death and cardiovascular events in elderly patients with dementia-related psychosis. Okay, that's why we usually do not use low-potent antipsychotics in elderly in general. Okay, let's talk about weight gain. It is common, yes, many experience and or can be significant in amount actually. Sedation, it is problematic. Tolerance to sedation can develop over time, but it is problematic sedation. It has a problematic sedation side effect. What to do about side effects? Usually wait. Okay, wait. And for motor symptoms, you can add an anticholinergic agent. You can reduce the dose. And for sedation, you can give at night. You can switch to an atypical antipsychotic. For weight loss, exercise programs and medical management for high body mass index and diabetes, dyslipidemia and such. Best augmenting agents for side effects is benztropine or trihexyphenidyl for motor side effects. Of course. So benztropine and okay. Sometimes amantadine can be helpful for motor side effects. Amantadine. Benzodiazepines may be helpful for akathisia, of course, and many side effects cannot be improved with an augmenting agent, so you should manage about that. Okay, what about dosing and usage? So the usual dosage range is from 200 to 800 milligram per day. You can see it obviously. The drug here is not potent, or it has low potency at least. So dosage forms, we have tablets of 10, 25, 50, 100 and 200, capsules of 30, 75 and 100, 150, ampules of 25, 1 and 2 mil. Okay. Ampule of 25 milligram per mil. We have 1 mil and 2 mils. Okay, milligrams, milliliters. And we have vials of 25 milligram per milliliter, which include, okay, 10 milliliter. Liquid of 10 milligram per 5 milliliter. And we have suppositories of 25 milligram and 100 milligram. Okay, how to dose? In psychosis, you increase dose until symptoms are controlled. After 2 weeks, reduce to lowest effective dose. For psychosis intramuscularly, it varies by severity of symptoms and inpatient-outpatient status. So you can monitor patients inpatient and monitor side effects. That's not the case in outpatient patients. Anyways, dosing tips. Low doses may have more sedative actions than antipsychotic actions. Low doses have been used to provide short-term relief of daytime agitation and anxiety, and to enhance sedative hypnotic actions in non-psychotic patients, but other treatment options such as atypical antipsychotics are now preferred. Higher doses may induce or worsen negative symptoms of schizophrenia. Ampules and vials contain sulfites that may cause allergic reactions, particularly in patients with asthma. Okay. One of the few antipsychotics available as suppository. So this is chlorpromazine. Okay. Available as suppository. One of the few of them actually. Treatment should be suspended if absolute neutrophil count falls below 1000. Okay. Overdose. It can cause extrapyramidal symptoms, sedation, hypotension, coma, or respiratory depression. In long-term use, some side effects may be irreversible, like tardive dyskinesia. Habit forming? No. How to stop? You slow down titration of oral formulation over 6 to 8 weeks, especially when simultaneously beginning a new antipsychotics while switching, like this is cross titration. Rapid oral discontinuation may lead to rebound psychosis and worsening of symptoms. If anti-Parkinson agents are being used, they should be continued for a few weeks after chlorpromazine is discontinued. Okay. What about pharmacokinetics? The half-life is approximately 8 to 33 hours. We have some drug interactions. It may decrease the effects of levodopa, of course, dopamine agonists. May increase the effects of antihypertensive drugs, except guanethidine. Those antihypertensive actions chlorpromazine may antagonize. Additive effects may occur if used with CNS depressants. Some pressor agents like epinephrine may interact with chlorpromazine to lower blood pressure. Alcohol and diuretics may increase the risk of hypotension, reduces effects of anticoagulants, may reduce phenytoin metabolism and increase phenytoin levels. Plasma levels of chlorpromazine and propranolol may increase if used concomitantly. Some patients taking a neuroleptic and lithium have developed an encephalopathic syndrome similar to neuroleptic malignant syndrome. Other warnings and precautions: if signs of neuroleptic malignant syndrome develop, treatment should be immediately discontinued. Use cautiously in patients with alcohol withdrawal or convulsive disorders because of possible lowering of seizure threshold. Use with caution in patients with respiratory disorders, glaucoma, or urinary retention, because of the side effects. Avoid extreme heat exposure. Avoid undue exposure to sunlight. Antiemetic effects of chlorpromazine may mask signs of other disorders or overdose. So suppression of cough reflex may cause asphyxia, of course. Use only with caution if at all in Parkinson's disease or Lewy body dementia. You should not use that. Okay. Do not use if patient is in a comatose state. Do not use if patient is taking metrizamide or large doses of CNS depressants. Do not use if there is a proven allergy to chlorpromazine. Do not use if there is a known sensitivity to any phenothiazine. Okay. This was about dosing and others. Let's talk about special population. With renal impairment, use with caution. Hepatic impairment, the same thing. For cardiac impairment, cardiovascular toxicity can occur, so especially orthostatic hypotension. In elderly, lower doses should be used and patient should be monitored closely. Often do not tolerate sedating actions of chlorpromazine. Although conventional antipsychotics are commonly used for behavioral disturbances in dementia, no agent has been approved for treatment of elderly patients with dementia-related psychosis. Elderly patients with dementia-related psychosis treated with antipsychotics are at an increased risk of death compared to placebo, and also have an increased risk of cerebrovascular events. So, for children and adolescents, can be used cautiously in children or adolescents over age 1 with severe behavioral problems. Oral up to 0.25 mg per deciliter every 4 to 6 hours as needed. Rectal to 0.5 mg per deciliter every 6 to 8 hours as needed, or IM 0.25 mg per deciliter every 6 to 8 hours as needed, and the maximum of 40 mg per day under the age of 5 and 75 mg per day between 5 and 12 years of age. Do not use if patient shows signs of Reye's syndrome. Okay, so generally consider second line after atypical antipsychotics, of course. So we do not use first generation antipsychotics usually. They are considered as second line after atypical. Okay, for pregnancy, effective June 30, 2015, the US FDA requires changes to the content and format of pregnancy and lactation information on the labels. So you have some changes, including the elimination of pregnancy letter categories. Okay, so the pregnancy and lactation labeling rule or final rule applies only to prescription drugs and will be phased in gradually for drugs approved on after 2001. So we use this. Okay, controlled studies have not been conducted in pregnant women. There is a risk of abnormal muscle movements and withdrawal symptoms in newborns whose mothers took an antipsychotic during the third trimester. Symptoms may include agitation, abnormally increased or decreased muscle tone, tremor, sleepiness, severe difficulty breathing, and difficulty feeding. Reports of extrapyramidal symptoms, jaundice, hyporeflexia in infants whose mothers took a phenothiazine during pregnancy. Chlorpromazine should generally not be used during the first trimester and should be used during pregnancy only if clearly needed. Psychotic symptoms may worsen during pregnancy and some form of treatment may be necessary. Atypical antipsychotics may be preferable to conventional antipsychotics or anticonvulsant mood stabilizers if treatment is required during pregnancy. Atypical is the solution. About breastfeeding, some drug is found in mother's breast milk, but effects on infant have been observed. So we have dystonia, tardive dyskinesia, and sedation can happen. So recommended either to discontinue drug or bottle feed. So that's the recommendation. Discontinue or bottle feed. Okay, let's talk about the art of psychopharmacology. Potential advantages here. Intramuscular formulation for emergency use. We have that. Patients who require sedation for behavioral control. We can use this for it. Potential disadvantages like patients with tardive dyskinesia, children, elderly, and patients who wish to avoid sedation. The primary target of symptoms are positive symptoms of psychosis, motor and autonomic hyperactivity, violent or aggressive behavior. Here we have some clinical pills. Chlorpromazine is one of the earliest classical conventional antipsychotics. Chlorpromazine has a broad spectrum of efficacy, but the risk of tardive dyskinesia and the ability of alternative treatments make its utilization outside of psychosis is a short-term and second-line treatment option. Chlorpromazine is a low-potency phenothiazine. Sedative actions of low-potency phenothiazine are an important aspect of their therapeutic actions in some patients, and side effect profile, of course, in others. Low-potency phenothiazine, like chlorpromazine, have a higher risk for cardiovascular side effects. Patients have very similar antipsychotic responses to any conventional antipsychotic, which is different from atypical antipsychotics, where antipsychotic responses of individual patients can occasionally vary greatly from one atypical antipsychotic to another. Okay, this is important to know. Patients have very similar antipsychotic responses to any conventional antipsychotic, which is different from atypical antipsychotics, where antipsychotic responses of individual patients can occasionally vary greatly from one atypical antipsychotic to another. Patients with inadequate responses to atypical antipsychotics may benefit from a trial of augmentation with a conventional antipsychotic, such as chlorpromazine, or from switching to a conventional antipsychotic such as chlorpromazine. What is that? Again. So, anyways, well, we've got the idea. However, long-term polypharmacy with a combination of a conventional antipsychotic such as chlorpromazine with an atypical antipsychotic may combine their side effects without clearly augmenting the efficacy of either. So, you should use one if you can. For treatment-resistant patients, especially those with impulsivity, aggression, violence, and self-harm, long-term polypharmacy with 2 atypical antipsychotics or 1 atypical antipsychotic and 1 conventional antipsychotic may be useful or even necessary while closely monitoring. In such cases, it may be beneficial to combine 1 depot antipsychotic with 1 oral antipsychotic, and that's good. So that's it. We have some suggested readings if you want.